Hello, everyone, and thank you for attending today's webinar. Before we begin, we wanted to cover a few housekeeping items. At the bottom of your screen are multiple application engagement tools you can use. All the engagement tools are resizable and movable, so feel free to move them around to get the most out of your desktop space. You can expand your slide area or maximize it to full screen by clicking on the arrows in the top right corner. If you have any questions during the webcast, you can submit them through the Q&A engagement tool. We will try to answer these during the webcast, but if a fuller answer is needed or we run out of time, we will answer later via email. Please know we do capture all questions. At the left side of your screen, you will find a list of resources related to this webinar. We encourage you to download any resources or links that you might find useful. For the best viewing experience, we recommend using a wide internet connection and closing any programs or browsers sessions running in the background that could cause issues. Webinars are bandwidth intensive, so closing any unnecessary browser tabs will help conserve your bandwidth. A recording of the webinar will be shared with the registrants approximately 2 days after the event. I will now hand it over to Dr. Daniel Nieto. Thank you.
Hello, everybody. First of all, thank you very much for inviting me to be able to speak in this webinar regarding the use of lasers in managing rosacea. This is the agenda I'm going to talk about. I'm going to make a brief introduction about some general characteristics of rosacea. Afterwards, I'm going to try to review the most current literature regarding the use of both PDL and YAG to treat rosacea. And based on this current literature, I'm going to try to review also which parameters and which are the things that I do in my clinic to treat this patient, and case reports to run it all. Regarding a brief introduction, as you very well know, rosacea is a high prevalent disease, above all in fairer skin types 1 and 2. It's estimated to have a prevalence of around 1 to 10%, but it's probably underestimated because most of the patients may not seek for a medical doctor to review or to assess this condition. It's more prevalent in women than in men and above 30 years of age. Although the pathogenesis is not very clear, there are some theories regarding the cause of rosacea, including the immune disbalance, also the pathogenesis related to some microorganisms such as Demodex, and above all, vascular hyperactivity. In 2002, the National Rosacea Society established the 4 main types of rosacea, which are the erythematolangictatic rosacea, which is the most frequent one, the papulopustular one, phymatous, and ocular. Just notice that the portfolio of the Vivim Prima, which is the latest device I'm going to talk about, includes the treatment of most of these conditions. Here you've got some cases taken from the literature. You see the erythema, very typical of rosacea, some telangiectasia on the nose, a papulopustular eruption, ocular rosacea with this telangiectasia on the eyelids and the sclera. The phymatous rosacea with these changes on the soft tissues, this enlargement of the nose and of the parts of its face. And on the bottom right of the slide, you see a more severe case of one kind of rosacea, which is the lupus cutaneous disseminatis falciae, which is an inflammatory form of rosacea. There are a lot of different treatments we can use in rosacea. The first of all is avoid general triggers such as sun exposure, a lot of physical exercise, use of alcohol or spicy foods. It's very important to moisturize the skin, use gentle cleansing and sun protection. There are a lot of topical and oral treatments, including a variety of antibiotics, ivermectin, or even low dose of retinoids, and last but not least, the use of light devices. In this particular, the use of vascular lasers such as PDL and YAG or KTP are very important. Also, the use of IPL, photodynamic therapy, and ablative lasers, above all in phymatous rosacea. I'm going to talk about the Vivim Prima, which includes both PDL and the 1064 long pulse and the YAG, which is the laser I use in my clinic. As you very well know, these vascular lasers use oxyhemoglobin as a target. So using these lasers, they're going to heat up the oxyhemoglobin. This increase in the temperature inside the vessel is going to coagulate the vessel via endothelial damage, and this is going to cause a reduction in the vessel density of the skin. Here you've got the use of lasers is so important when managing rosacea since the beginning of the use in the 80s. That most current guidelines include the PDL or NIAC or IPL as a main parallel of treatment for this condition. For example, you have here the American Acne Rosacea Society with its guidelines. They include the PDL as an important modality in rosacea treatments. Also, the Netherlands guidelines, both including the vascular lasers for erythema and telangiectasia, and also the ablative lasers for the use of fimatous conditions, and also the Swiss guidelines, which say that the PDL represents a safe and effective treatment option for facial erythema and telangiectasia. So the use is more and more important. They've increased the use in the treatment of rosacea and of different kinds of rosacea, and now there is very ground evidence of the use of these lasers. In the second part, I'm going to try to review this evidence of the use of lasers in rosacea, both the PDL and the NDIAC, based on the current literature. This is the main article I'm going to review. It was published last year in 2020, and it contains the most solid evidence regarding the use of these lasers based on patient series, also on some clinical trials made with the use of lasers. Regarding the PDL, both the 585 and 595 devices are the treatment of choice for telangiectasias and superficial vascular lesions. As you know, they target the ophthalmoglobin located at maximum depth of 1 or 2 millimeters of depth. So they are very useful when treating this superficial telangiectasia. This is one of the first articles that were published regarding the use of PDL and their utility treating rosacea. But since that article, there are other articles that try to resolve some questions that you may be faced with when treating these patients. For example, it's more important to use purpuric or subpurpuric settings. It is useful and safe to use topical and oral treatments with treating patients with PDL, and which is the long-term effect of the PDL when treating rosacea. I'm going to try to elucidate all these questions with the subsequent papers I'm going to present you. Beginning with the first one, which is one of the most important ones, is that you prefer to use purpuric or is better to use subpurpuric settings when using PDL to treat patients with rosacea. In this article, 2005, they include 9 patients, and they made a split-face control clinical trial. They use subpurpuric settings in the half of face, and they use purpuric settings in the other half. In the subpurpuric half, they use 4 passes, 4 subsequent passes of subpurpuric settings, and the other one just 1 pass of purpura settings. And they make an evaluation of the degree of erythema from 1, which is minimal erythema, to 4, which is severe erythema. And they see that on the side where they use subpurpuric settings, 4 passes of subpurpuric settings, the improvement of the basal erythema is around 32%, whereas in the side treated just with the purpura settings, the improvement is just 3%. So this article may lead you to think that use of various passes of subpurpuric settings is better to treat just the erythema on patients suffering from rosacea. This paper also suggests the same. They include 19 patients from 36 to 69 years of age, both all women, and they just make 1 pass of subpurpuric settings using the 15 millimeter spot, 3 milliseconds of pulse direction, and between 6.25 and 7 joules per square centimeter to treat all the general erythema. And they see that with using this larger spot and subpurpuric settings, the mean of improvement is over 64%, and more than around 50% of the patients improve over 50% of the erythema. So using subpurpuric setting is very useful and is very safe to treat the patients with just erythema. When you go to telangiectasia is a bit trickier to treat, because you have to take into account when establishing the settings for this condition, a concept which is the TRT. The TRT, or the thermal relaxation time, is the time that it takes a vessel to reduce the temperature they achieve when being treated with a laser to its half. So when you use a laser, you're going to increase the temperature of the vessel to a maximum. The time it takes to this maximum temperature to diminish to a half fix, it's called the thermal relaxation time. In order to be able to coagulate a vessel, you have to use pulse duration shorter than this thermal relaxation time. So if you use longer pulses than the thermal relaxation time of the vessel, you're not going to be able to create an immediate coagulation rate. This thermal relaxation time is directly proportional to the square of the diameter. So larger vessels are going to need, or you're going to be able to use larger pulse duration, whereas smaller vessels you're going to need to use shorter pulse duration. So for example, the 0.5 or 1.5 milliseconds is going to be useful to treat small vessels, whereas 30 or 40 milliseconds of pulse duration is going to be more useful when treating larger vessels. When you've established which is the pulse duration you're going to use when you're going to treat the telangiectasia, you have to decide whether to use fluence, which is going to be purpuric or subpurpuric. Regarding the literature, in the same article that I told you about before, they make the same comparison between 4 subpurpuric passes on one side and 1 purpuric pass on the other side. And as they see, you see that both the area cover telangiectasia and the vessel vaporization improve more with purpuric settings. So when you treat erythema, subpurpuric is better, but when you treat just telangiectasia, it seems that purpura may be more useful when trying to make all these telangiectasia disappear. In the same view that the previous article, this also is a prospective randomized controlled non-blinded clinical trial where they include 11 patients. In these 11 patients, they try to establish a purpura threshold, and when they've established the purpura threshold of the patient, they treat half the face with subpurpuric settings and the other half with purpura settings, and they make an evaluation of both the telangiectasia and the purpura intensity scale in a scale between 1, which is minimal, to 5, which is a lot of telangiectasia and a lot of purpura. And as you see here in the table on the top right of the screen, you see that when using non-purpuric, you just see an improvement of 11%, and when you use purpuric settings, you get an improvement of around 48 or 49%, depending on the diameter of the vessel. So both sides improve, but it is greater when you use purpura compared to when you use subpurpuric settings treating this telangiectasia. And it may seem that larger vessels may benefit more from purpura settings. After this last paper, another group tried to establish what happens when you use subpurpuric settings that are very close to this purpura threshold. So they include 12 patients, and they just make one treatment with this parameter, which is 6 milliseconds of pulse duration, 7 millimeters of spot, and between 7 and 9 joules per square centimeter. With these parameters, they get a transient purpura just lasting for a few seconds. They do not say how many seconds that is last, but just transient. So it's not going to be an everlasting purpura. And when using this subpurpuric setting, but very close to a purpura, they see that 3/4 of the patient improve over 25% of the telangiectasia of the face. So even though purpura has been shown to be better than subpurpuric settings for treating just telangiectasia, when you use parameters that are very close to the purpura, causing a transient purpura but not lasting purpura, their response may be as well as when just using definitive purpura. In this article in particular, they see that 83% of the patients stated a moderate to excellent self-assessed response without any side effects, and they avoid the purpura downtime. As for the second question that I told you before, is it useful and is it beneficial and safe to combine topical treatments with PDL? There are several articles on this topic. For example, this first one, they include 15 patients, and they make a split phase clinical trial using just PDL on one side of the face and PDL combined with an iosine cream on the other side. And even though they do not see any difference statistically in objective response, they see that both the investigator's general assessment and the patient's general assessment are different, significant difference in favor of the side treated with an iosine cream. The same you can see with this other article with the increased 31 patients treated with PDL plus oxymetazoline cream, and they see that it's almost 85% of the patients get an improvement of the erythema and on the telangiectasia based also on the degree of the severity of the erythema. But greater improvement is seen when the erythema is high, when the CEE scores with its general erythema scores are higher. Also, you can use ivermectin to treat both the erythematotelangiectasia rosacea and the papulopustular rosacea. In this article, it includes 30 patients. 15 of them just PDL, the other 40 with PDL plus ivermectin, and they see that also there are no significant differences in both sides regarding the objective response. Both the investigator general assessment and the patient general assessment are also significant difference better in favor of the combination of ivermectin and PDL. And something that I find also important is, which is the results using anesthesia. There are some patients, above all some adolescent patients and some patients with rosacea, who have very sensitive skin that may complain about the use of lasers on the skin because it's itchy, it's a bit uncomfortable. So they may ask you to try to apply some topical anesthetic cream prior to the laser. So in this article, they include 69 patients, and they make half of patients just with PDL, and the other half with topical anesthesia 1 hour previous to the application of the PDL, and they see that there are no significant difference in the erythema. I prefer not to use a topical anesthetic because I use a very large spot when treating rosacea, and the session in itself is very short, and the patient do not complain about the treatment. But if you've got this kind of specific patient, which is very sensitive to the skin, or if it's a child or an adolescent, you may use the topical anesthesia with a very ground evidence that is going to be also useful, despite the theoretical vasoconstriction caused by this kind of topical anesthesia. Regarding the oral treatment, also the combination with minocycline or doxycycline has been proven useful when treating rosacea and very safe. In the first article that I present you here, they see that using minocycline combined with the PDL does not only improve the results, but also it diminishes the recurrences 1 year after treatments. And when combined with doxycycline, it's very useful, it is very safe, there is no side effects, especially no photosensitivity. And this is mainly due to the fact that both minocycline and doxycycline has a range of photosensitivity between the 325 and 425 nanometers of wavelength, which is very far from the 595 or 585 nanometers of the PDL. Also, I find this very important when treating inflammatory rosacea. The PDL does not only reduce the skin, the vascular density, but it also helps you with decreasing the demodex density. Demodex is a microorganism that has been related to flares of rosacea, and it may be important the pathogenesis of rosacea. So this article, they include 31 patients, and they try to evaluate the demodex density prior and after the use of the PDL, and they see that a significant decrease in the demodex density, and more than 1/3 of the patients became demodex negative after the treatment. So in these conditions, with the it's combined with a demodicosis, which is an increase in the demodex density, you can also use PDL very safely and with great results. And to finish with the PDL, results of the PDL, because there are a lot of patients that ask you, okay, I'm going to receive between 1, 2, 3, 4, 5 sessions of PDL, and what's going to happen after? I'm going to have to receive more sessions. This is going to be like I was before the treatment, just in 2 months' time, or what's going to happen? So in this article, they include 14 patients with 13 patients with erythematocytic rosacea and 1 patient with papulopustular rosacea, and they use between 1 to 4 sessions of PDL. They make an evaluation of the investigation general assessment, patient satisfaction, and quality of life. And they see that using the PDL improves significantly the 3 things: the erythema, the telangiectasia, and also the effects on the life quality. But what is more important for me, that when they ask this patient what happens with this condition after the treatment, they see that over 85% of the patients say that they have a moderate or significant benefit after 22 months of follow-up in average. So even though you just have between 1 to 4 sessions, most of the patients, even 2 years after having received this session, they're going to express a moderate to significant benefit. It's not only to be able to improve the symptoms at the moment, but also in long term, which is something very useful for you and something that you can explain to the patient. Regarding the use of the Nd:YAG, as you know, Nd:YAG it's a deeper laser. Is going to be useful to treat these vessels which are between 4 to 6 millimeters of depth. But you have to use high fluencies to destroy these vessels because the absorption by the oxyhemoglobin is much lower than with the PDL. Using these high fluencies may be a bit trickier because you may cause some blistering, scarring, and other side effects that are less frequent than when using the PDL. But on the other side, since the absorption development is much lower with the Nd:YAG than with the PDL, it is much safer when you treat patients, the very rare patients with rosacea in dark skin types such as phototype 3 or 4. In this article, they try to evaluate the efficacy of the Nd:YAG when treating both the erythematotelangiectatic rosacea and the papulopustular rosacea. They use a very small spot with 2-3 millimeters, 15 to 20 milliseconds of pulse duration, and between 100 and 160 joules per square centimeter. And they apply sessions every 3 or 4 weeks. And as you see here, most of the patients grades a good to excellent response, over 80% of global improvement in patients with erythematotelangiectatic rosacea, and over 63% of patients with papulopustular rosacea. So it's effective in both types of rosacea, very safe, and with good results. More concretely, more precisely, when you treat patients with papulopustular rosacea, this article includes 30 patients. They separate patients with moderate rosacea, which they apply Nd:YAG only, and patients with severe rosacea, where they apply the Nd:YAG combined with doxycycline. They do 3 sessions with a gentle max settings, which is 10 millimeters, 50 milliseconds, a very long pulse, and between 40 and 50 joules per square centimeters. And as you see here, the erythema, the papules and pustules, the edema, and most of the questions asked for the patient self-assessment improved with these settings of the Nd:YAG, and both the moderate and the severe patient get an excellent to good response without any side effects, despite the combination with oral tetracyclines. And when you compare PDL and Nd:YAG when treating, for example, the nasal telangiectasia, we've got this article where they include 20 patients with bilateral nasal telangiectasia. On the right side, they applied long pulse Nd:YAG with a very small spot. And on the left side, they use the PDL. And they say that over 50% of the patients in both sides get a good or excellent response, although PDL seems to be safer and better when there is also erythema around the telangiectasia and in mild telangiectasia. And long pulse Nd:YAG is safer and is more useful in marked thick dilated vessels. So after giving all this information on all this evidence on the use of PDL and the Nd:YAG when treating rosacea, what do I do in my clinic to try to summarize all this information I give you and give you some tips that you can use when treating patients with rosacea regarding the use, for example, of Vivim Prima, which is the device that I use. So I'm going to divide this part on the 4 main conditions that I treat, which is telangiectasia alone, erythema, papulopustular rosacea, and fibrous rosacea with a very congestive aspect. When treating telangiectasia, you have to differentiate those patients who have a very high density areas of telangiectasia and those patients who have just a small or lower density. When you've got high density areas, you usually have very, very fine dilated vessels or covering a greater areas of the skin. In these cases, I tend to use a very circular spot between 10 to 15 millimeters. I prefer to give between 1 to 3 passes of subpapillary settings between 3 and 6 milliseconds and 6 and 8 joules per square centimeters. And I look for this transient purpura I told you before. If you do not have, if you are very dubious about which is the purpura threshold, you may try to make a purpura test, and when you get the purpura test, you may use these subpapillary settings very close to this purpura threshold, which is going to be very good for the patient. And just looking for this transient purpura and a bit of moderate to moderate erythema after the 1 to 3 passes with a 10 to 20% overlap. When you've got finer, when you've got lower density areas of telangiectasia, they use the superficial and small vessels. I prefer to use the 3x10 linear spot because it's going to apply just over telangiectasia, leaving the surrounding area without any treatment. I prefer to use the purpuric settings over the subpapillary setting, but that's something that you have to discuss with the patient also, because there are some patients that may not afford to have that downtime caused by the purpura. So you may use these subpurpura settings very close to the purpura, but you may explain to the patient that when treating telangiectasia, which are thicker or which are a bit larger, then you may use more sessions, and the results may not be as effective as when using just purpura settings. I just make one pass per vessel, and I see the same a purpura located on the vessel. Using very thick vessels, for example, the vessels which are around the nose, depending on the depth that you see of this vessel, when they are more superficial, the small ones, I try to the small vessels. I prefer to use the PDL with a 3 by 10 millimeter spot. But when they are thicker, they are deeper vessels, I prefer to use the Nd:YAG. I use the small spot that I've got, which is the 1.5, because it's going to be more superficial, but deep enough to treat these vessels without causing any scarring or blisters. I use between 10 to 40 milliseconds, depending on the size of the spot and the size of the vessel. When the vessel is a bit larger, I try to use longer pulse duration because they are going to be safer. When the vessel is smaller, I use shorter pulse duration, and between 180 and 250 joules per square centimeter. When the erythema is concerned, when there is just erythema, I use the largest spot I've got, which is the 50 millimeter spot. This is mainly due to shorten the duration of the session. You're going to cover the area of the face faster than when using a smaller spot, and the session is going to be shorter, so it's not going to be so uncomfortable for the patient. And also, when using the 50 millimeter spot, you gain a bit of more depth when treating this patient. I always use subpurpura settings between 1 to 2 passes. I'm looking for a mild to moderate erythema, depending also on how the patient feels with different passes, and between 10 to 20% of overlap. When there is erythema and telangiectasia, I first treat the telangiectasia, and then I treat the erythema. Treating also the telangiectasia where the erythema is as a background. And if there are a lot of flares or flution associated, I combine it safely with calcineurin inhibitors, niacin cream, or oxymetazoline cream, as I told you before. When papulopustular rosacea is concerned, usually you find a papulopustular rosacea surrounded by erythema. It's very rare to find just few papules or pustules without any erythema around them. So I first treat the erythema with the parameters I told before, and then I make a second pass over the papules and pustules with the 10-10-10 parameters, 10 millimeters, 10 milliseconds until 10 joules per square centimeter, not creating purpura and enhancing the anti-inflammatory effect of the PDL. I combine it with local therapies such as topical metronidazole, calcineurin inhibitors, or ivermectin, or even oral therapies such as doxycycline, minocycline, or very low dose of isotretinoin very safely. I find that the combination of isotretinoin with the PDL is safe when you use low doses of them, and I have so far no side effects with this combination. Lastly, when female rosacea is concerned, of course, the use of ablative lasers are more useful when treating this kind of rosacea. But if it has a very congested aspect, I prefer to use first the PDL to try to diminish all these redness, all this erythema, all these dilated vessels, and then I use the ablative lasers to try to remodulate the soft tissues. Okay, so just to round it all up, I'm going to give you some examples of patients of my clinic with the parameters I use and the results I've got with the Vim Prima. This 55-year-old patient with telangiectasia, pure form of rosacea, with these very low density areas of telangiectasia located in both cheeks. I used the 3 by 10 millimeter spot. I asked the patient if he could afford to have a bit of purpura, because it was more effective than using subpurpura. The patient worked with the public, so he could not afford to have a purpura on the face. So I decided to use subpurpura settings, telling the patient that the results may not be as good as when using purpura settings. But even though after just 2 sessions, you see that most of the telangiectasia on the left cheek and also here on the right cheek has disappeared completely, and the patient is very happy with the results. Although we may have to continue with the sessions to try to erase all this telangiectasia on the face. This is the patient with very thick telangiectasia located on the nose, but very superficial ones. Also, I use a 3x10 in this case. Since as you see, the vessels are a bit larger than the previous patient, I use a larger pulse duration. In this case, instead of 6 milliseconds, I use 10 milliseconds with 10 joules per square centimeter. As well as the previous patient, I didn't use papillary settings because the patient couldn't allow that, but the results after just one session is very good. Most of the erythema has resolved, and also those dilated vessels have disappeared. This is another patient with a pure form of erythematous rosacea with very frequent flares. In this case, I used the 15 millimeter spot with 3 milliseconds, 6.75 joules per square centimeter, not purpuric settings, and I combined it with a topical pimecrolimus because the patient suffered from frequent flares. And after just 3 sessions, this is the result. Most of the erythema is resolved. And I saw the patient the other day, and after 1 year, without any kind of treatment, the patient remains okay, and she has not so many flares as before the treatment with laser. This is a bit more complicated patients. This is a 30-year-old patient with lupus rosacea and also melasma. She was taking hydroxychloroquine for the treatment of the lupus, and she was also taking oral tranexamic acid for the melasma. I decided to use also the subpapillary settings to treat the rosacea with the 15 millimeter spot, 3 milliseconds, and I reduced the fluence to 6.25 joules per square centimeter, mainly due to the phototype of the patient and also because I didn't want to create a flare of the lupus or the melasma. And just after 2 sessions, you see that most of the erythema on the cheeks, on the nose, on the forehead has completely resolved. No flare of lupus, no flare of melasma either, and the patient is very happy with the results. This is also a 25-year-old patient with lupus rosacea, a mixed form of erythematous rosacea, also with papules and pustules located on the face. She was also taking oral hydroxychloroquine for the treatment of lupus, and I decided to use the 50 millimeter spot, 3 milliseconds, and just 6 joules per square centimeter due to the very inflammatory condition that she was having when she came to the clinic. And just after 2 sessions, you see the most of the erythema is resolved, some of the papules and pustules are resolved also, and the patient continued to come to go on with the session just to try to make the best improvement with her. And this is the last patient I'm going to present to you. This is papulopustular rosacea, also with erythema and thick telangiectasia on the skin. Although the erythema and the telangiectasia did not worry the patient suffered a lot from a rate of itching from the papules and pustules. There are some areas where you see also very fine scaling, suggesting a combination of rosacea and demodicidosis. So I combined the laser with topical ivermectin. I made a first pass with a 15 millimeter spot with 3 milliseconds and 6.5 joules per square centimeters, and then a second pass over each and every pustule with 10 joules per square centimeter, 10 parameters, and the topical ivermectin. And just after sessions, you see most of the inflammatory lesions have resolved, the erythema has improved also, and now that the inflammatory lesions have resolved, I am going to try to go on to treat the vessels, the thick dilated vessels the patient wants to, and also the erythema. So thank you very much for attending the webinar. I hope that it's been useful for you. That's all.
Thank you, Daniel, for your fantastic presentation. I will try to keep up the level that you set. Thank you, Candela, for the invitation, and thank you all for joining us this afternoon discussing the treatment of rosacea using light-based devices. We'll cover the treatment of rosacea using our IPL system, Norlis. But first of all, I would like to cover some points extra about our basis, rosacea, and just adding some points to Daniel that either the estimated prevalence is low. We know that this is a condition that is underdiagnosed. So it's estimated that on low Fitzpatrick, the prevalence might be over 50%. And we know that the pathogenesis is poorly understood, but there are some mechanisms that we are already aware about, namely altered neurovascular signaling, immunological dysregulation, and the colonization from some microorganisms as the Demodex, as Daniel has already discussed. We know that besides the phenotypes that we can find, we also have some symptoms that we have to look out for them, because our treatment and our endpoint for our treatment should be also symptom-led. We already know, and Daniel has already covered, that we have some aggravating factors that we have to discuss with our patient to be aware of them, and for the patient to manage his chronic condition. And about the pathophysiology, on 20 minutes, we cannot cover all of the pathophysiology. We would need 20 days. But the first idea that I want you to keep is that is multifactorial, multi-pathway, and multicellular. And we have to acknowledge that and know that to address and to propose proper treatment to our patients. In a kind of a very simple resume, we have to consider mainly three topics. First of all, the skin barrier dysfunction, the inflammation, and the angiogenesis that is present on this pathology. The skin barrier dysfunction is mainly mediated by the TLR2 and the KLK5, and the two examples, or the main examples for treatment is to use retinoids and azelaic acid. On the part of inflammation, we have two main actors here, that is the cathepsin, the LL37, and interleucin 17, and we can basically, almost all of the therapies that we are using are addressing these two pathways, mainly the IL-17 pathway. And here, the laser therapy already has an important role. And at the end, the angiogenesis, mediated by the VEGF and the neuropeptide S1P, that we can address with laser therapy and botulinum toxin type A. I would like to bring to you the last rosacea consensus, the Rose Code 2019. And on this consensus, there are three topics that I want to focus on. Mainly that the objective of our treatment plan is to provide to our patients a nearly zero symptoms condition, that the therapy should be phenotype-led, and normally a combination therapy, and that the phototherapies are important as adjunctive or main therapy on all the phenotypes. This consensus was updated, and basically the adrenergics and beta blockers orally are basically took off from the recommendations, only are used on very specific situations. And basically, we can use the phototherapies to cover the erythema, the inflammatory part, the telangiectasia, and the fimatous part. And bring you, although is not present on the table, the laser and light therapies on the inflammation part, we already have plenty of data and evidence regarding the use of the light therapies on the control of the inflammation, mainly on the IL-17 pathway and also on the IL-1B, 1-beta pathway 2. We are discussing the use of the nervous system treating rosacea, and the Norway system has 4 foundational technologies. The IPL, that's called SWT, 2 non-ablative fractional lasers, and an NDI of 1064. The SWT basically has 8 applicators and has 2 unique features that we will cover to understand why this tool is very important and useful to deal with rosacea. This is just a summary of all the applicators. I would like to start to focus on the band that IPL use. We know that the IPL is a non-coherent light source, so more than a wavelength, we have a band of wavelength. On Norley system, the SWT technology filters out possible harmful wavelengths that are the near infrared and infrared part of the spectrum that basically is just on the water curve. This means that all of our energy will be delivered to our main chromophores, namely the melanin and the hemoglobin. And here, covering rosacea, we will focus on PR applicator that has a band starting on 530 and ending in 750, that allow us to cover the first and left part of the absorption curve of the hemoglobin. Also, filtering out water, we won't need cooling on the most part of our treatments, and this will lead to an improved safety and efficacy of our treatments. The second feature that I would like to cover is the use of the 2 millisecond pulses that can be almost comparable with a PDL system. This technology is exclusive and unique for this system and allows us to use down to 0.5 milliseconds in a single pulse. And this will be useful for treating diffuse erythema and other vascular issues, as for instance, portland stains. Treating rosacea with Nordlis. First of all, how to set up our treatment. First, we should initiate medical treatment and address the 3 conditions and situations that I told you about right on the start. And normally, I combine a retinoid with an IL-17 pathway modifier, with moisturizer and sunscreen, and obviously teach the patient that in rosacea, less is more. So the patient should comply with a sensitive skin suitable regimen and products, and avoid other chemicals that might work as an irritant on this already sensitive skin. And afterwards, we should set up our laser treatment, again, phenotype led. Normally, we should start treating the diffuse erythema, because normally the diffuse erythema is in an upper layer of the skin comparing with the telangiectasia. So this can work as an optical shield. So if we treat first the erythema, afterwards we can improve the efficacy of the telangiectasia treatment. Afterwards, we should think about the interaction of light with the hemoglobin. And we know that on the curve of absorption, on the first shot, we can induce the formation of methemoglobin. And the methemoglobin has an absorption much more intense comparing with the oxyhemoglobin. So it's important or to overlap the IPL shots or to do a multipass to improve our efficacy of the treatment. On the treatment, we should first of all address and assess the chromophore density. If we have a diffuse redness or a microreticular telangiectatic pattern, if we have a diffuse redness, we should go for the 1.5 milliseconds setting. And if we have this microreticular network, we should go for the double pulse of 2.5 milliseconds with 10 milliseconds of delay between them. Basically, the parameters that we should choose about the fluence, we should use the guided mode to have a fluence space, and afterwards increase 1 joule to the setting provided. Also, we should also remember that on the forehead and on the neck, we should lower 25%. 20 to 25% of the energy, because the skin is more sensitive, because it has less appendages, and the healing could be compromised. Don't forget the overlapping question. And if we perform the treatment with pressure over the skin, we are taking out our chromophore from our treatment site. So we should not apply any pressure on the skin. Also, we have to remember that we have a crystal and the skin, and we have to use a coupling agent to have proper penetration of the energy. Normally, it's needed. If we need to multipass, we should apply some cooling between the passes. When do we need this multipass? Sometimes we have some diffuse redness and a high density pattern of this microreticular telangiectatic pattern. So we can do the first pass with the 1.5 milliseconds pulse and cool the skin, and afterwards do a second pass with the 2.5 pulse regimen to address both conditions at the same time and improve efficacy. Normally it's needed 2 to 4 sessions, and we should set the treatments 4 weeks apart to have a proper healing between sessions. We know that this condition is a chronic condition, and normally the patients will need some maintenance sessions, and they will need 1 to 2 sessions, 1 to 2 times per year of maintenance to maintain the condition, not only aesthetically good, but also symptom-free. Don't forget the symptom part. These are some cases treating the diffuse erythema and the microreticular part. Sorry, this was a video that is not actually working, but here with 3 sessions, only with the 1.5 millisecond pulse with 50% of overlapping, we have a nice clearance of the erythema. And this patient told me that just after the first session, the symptoms associated was almost 100% mitigated. Treating the telangiectatic part. First of all, what we should do is to assess the predominant chromophore. And if it's pink or red, as in most cases on the face, we will go for the PR applicator. If it's purple, we will go to the VL applicator. And if it's darker or deeper, we can use the NDAG applicator from Nordley system. I will not take any long talking about the thermal relaxation time and the pulse definition because Daniel already covered it. And basically, what I want to discuss with you is the concept of a square pulse. Because treating vessels, if we have a thin vessel, if we use a 10 per 10 pulse, that what means using 10 joules and 10 milliseconds, it's what is advisable for a medium thickness vessel. That is a vessel that has a diameter between 0.1 to 0.5 millimeters, a square pulse of 13, and if we have a thicker vessel that is more than 0.5 millimeters of diameter, we use 15 square pulse. Now I will present you some cases for treatment of telangiectasia. Here we have a single treatment using the PR applicator. Here the smaller one is what this S stands for on PRS. And only with a single treatment, we can actually see a nice improvement of the telangiectatic network. Here, this telangiectatic network on the nose and on the cheek after three treatments of a square pulse of 10 with this nice improvement. A similar case. Here, as the patient had some photoaging, this patient was treated with the VL applicator first and afterwards a touch-up with the PR 530. With this nice clearance of all of the telangiectatic vessels, probably it would be useful to perform another treatment with a square pulse of 8 to 10 to clear these residual lesions. Here a similar case using only IPL. Another case, after 3 treatments, telangiectasis of the nose, also with a great efficacy. Please be aware that this vascular system of the nose is a high-pressure system, so the recurrence of these vessels is pretty common after 6 to 9 months after treatment, and normally it's needed to retreat these patients from time to time. More cases of the nose. I would like to present you 3 more cases. This severe flushing using the very short pulse unique to the Norway system with this nice clearance, almost a PDL result with the short pulse and after 3 treatments. Another case, combined telangiectasias and the diffuse erythema after 3 treatments with a nice clearance. And this case with some papulopustular areas on the zone, treatment after 3 treatments with this nice clearance. And as aftercare, we should be aware that we can have some side effects that are possible, namely the erythema, the edema, and the purpura. We should prescribe for 3 to 5 days topical hydrocortisone 3 times daily and sunscreen. And for improve the comfort and to cool down the skin, we should advise our patients to apply or cold gauzes or cold thermal water in spray or even ice on the first hours. And the patients should avoid direct sun exposure and direct heat sources for at least 1 week after treatment. Some pearls treating this condition with IPL. I normally like to initiate medical treatment at least 2 weeks before white therapies, because we know that we are always inducing some worsening of the transepidermal water loss with the treatments, and improving the skin barrier function previously would limit a little bit the side effects from the treatment. We should think not on the pathology, but on the pathways that are involved, and we should cover therapeutically all of these pathways to get a nice result, not only phenotypically, but also from the symptoms too. Again, remember to address the skin barrier dysfunction, the importance of overlapping or multipassing, the issue of not applying pressure with the applicator on the skin with IPL is very important. And for the optical shield effect, we should treat the diffuse erythema first when we have erythema and telangiectasias at the time. If the diffuse erythema persists after the third treatment, consider the use of botulinum toxin injections, and you should schedule maintenance treatment sessions more to cover the symptomatic part rather than the aesthetical one. And concluding, we have with Norway's an unique and non-coherent light-based system that allows you to use 2 millisecond pulses, and its narrow band brings us the selectivity and thus the efficacy and the safety that we need to treat our patients. And with these unique features, we are meeting the needs when treating this complex pathology as rosacea. And we see the improvements also with the symptoms just after the first session. As this platform has no consumables, it's profitable with low running costs. And with these unique features, we can provide better results with less sessions. And normally, we have high satisfaction rates for patients, but for us too, that see these patients every single day. This was I brought to you today. Thank you very much for your attention. I think we will open to discussion and to question answering.
Thank you, Dr. Santos. Dr. Nieto, we have several questions we received. Dr. Nieto, do you want to start with your question?
Okay. The first question I've got is, how do you decide whether to treat rosacea with Vivin or IPL? Well, I find that both systems, both Vivin Prima and both the IPL, including Norlis, are very similar when used to treat rosacea. In my case, I use the PDL because that's the one that I've got, and I guess that Dr. Santos used the IPL because that's the one that he's got. But I think they're very similar to alternate between them. So any one of them is good to treat the condition. Above all, because now with the new IPL, the Norlis includes you can cause purpura using the very short milliseconds pulse, so you've got similar results. Okay, and the other question is, if I treat patients using oral isotretinoin or tetracyclines, actually I do when I've got patients with very severe inflammatory condition or with a lot of papules and pustules, I try to combine it with tetracyclines and isotretinoin. I begin first with the tetracyclines. As I told you before in the presentation, they've got photosensitivity range of wavelength, which is very far from the 595. They've got a range of sensitivity between 325 and 425 nanometers, so very far from the 595 of the PDL. So you can use it very safely with no side effects. And I've got also patients under oral isotretinoin. In treating patients with rosacea with isotretinoin combined with PDL, I prefer using low doses of isotretinoin between 5 to 10 milligrams per day, or even pulse doses of 20 milligrams every 3-4 days of isotretinoin. And also insist on sun protection and avoid all the other triggers that may cause a flares of rosacea. The results are very, very good.
Thank you. Dr. Santos, also some questions. Should I read them for you, Dr. Santos, or can you read them?
I can read them.
Perfect.
I have here a question about a particular patient that was treated for diffuse redness 4 times with IPL. And the face was cleared, and after that some telangiectasias disappeared, and after treating them with 11 joules at 13 milliseconds pulse, the redness and flushing got back. What do I suggest? Basically, the patient is getting back to the question of the multi-pathway issue, meaning that probably you are not covering all of the mechanisms that are leading to this problem. So I would suggest you to use something to control the inflammation, and mainly here the IL-17, and you can use a topical metronidazole, for instance, or if there is a neurogenic effect, consider to use microbotox injections to control the neurogenic part. This probably would be the next steps for me to go for. Maria, no, I don't know if Danielle has any question extra or.
I still see other two questions for you. One is, I didn't understand what the oxyhemoglobin multipass have to do with efficacy.
Basically, we have some forms of hemoglobin, and normally we're treating mainly the oxyhemoglobin. We know, and this is covered with several studies now, and some of them are not new. Let me get to the slide again. Basically, we know that on this case that we have a diffuse redness and the TRT is pretty low, and normally we have a high pressure system. This to induce an effect of photocoagulation is more difficult to achieve. And if we, with the first pulse, convert the oxyhemoglobin to methemoglobin, the methemoglobin has a higher absorption on this range of wavelength comparing with the oxyhemoglobin. So, and the presence of methemoglobin stays there for some minutes. So if we do multipassing or overlapping, as we are doing pulses sequentially, we will improve the efficacy for having a better absorption profile. Basically is why doing the multipass of the overlapping, we will improve the efficacy of the treatment.
Then another question is, when treating telangiectasia in widely involved areas, I use PR on telangiectasia parameters, not focally, and it works well, though it induces some edema for a few days. What do you think?
It's expectable to have that edema, and we have here we cannot use the square pulse strategy, because if we use the square pulse strategy, the amount of energy that we are using will induce a bulking that can lead to serious side effects as a second-degree burn. So if you use the standard settings that appears on Nordlis, even lowering 1 joule, that might be okay, even with some edema going on. And the other strategy is to cool down the skin very well before starting the treatment with that kind of strategy. But please be aware that this strategy is a high-risk strategy to use. But in well managed, I agree with you that it will give nice results, although with some side effects. Normally, when I need to use these kind of settings, I prescribe an oral corticoid for 3 to 5 days to reduce the edema.
Thank you. We also received another one, either for you or Dr. Nieto. Are you not worried about prescribing retinoids to people with sensitive skin?
Well, in my case, I use it in very selected patients with a very inflammatory rosacea, and he has not responded to previous topical treatments or even oral tetracyclines. And these cases, which are very resistant to different topical and oral treatments, I use very low doses of isotretinoin. You have to balance the benefits and side effects of the use of this treatment in patients with rosacea. But most of the times, in my experience at least, you see that most of the inflammatory lesions disappear, and once they disappear, you may discontinue the treatments and then go on with using other treatments. And the patient prefer to have a bit of side effects like scarring or a bit of dry skin, but with a marked reduction of the inflammatory lesions, which are very itchy and they cause a lot of problems in patients. So I just explain the treatments to the patient. I just try to make a good assessment, and in selected patients very resistant, I find it very useful and with no important side effects. I don't know if any more questions.
No, I don't see other questions. I also have a thank you for a great answer for the one given also from Dr. Santos. So I think we don't have other questions at the moment. So thank you very much, both of you, for this great webinar and all the nice cases presented as well.